Hi there, my name is Leonard and today I'll be discussing how to manage a failed airway. Pre-hospital intubation should follow a well thought out and systematic airway plan. An airway plan comprises of 4 individual subplans. Plan A is the initial intubation attempt and is aimed at maximising first pass success. If Plan A fails, then the reasons for the failure should be recognised and incorporated into Plan B, which is the second and final intubation attempt. If after the second attempt a tracheal waveform cannot be demonstrated on the monitor, the tube must be removed and a failed intubation declared to everyone on scene. At this point in time, it is crucial to move swiftly to Plan C, which aims to return the patient back to a pre-induction state by maintaining adequate alveolar oxygenation using one of 2 techniques. In Ambulance Victoria, the first technique implemented is bag mask ventilation. To perform effective bag mask ventilation, 2 factors must be present. Number 1 is a patent airway, and number 2 is a good mask seal. Let's explore how we can optimize both of these. It is important to understand that patients who are unconscious and paralyzed lack muscle tone in the upper airway, which can lead to obstruction by 3 main anatomical structures: the tongue, epiglottis, and soft palate. To overcome these obstructions, it is important to utilize a combination of positioning, manual maneuvers, and airway adjuncts. To optimize position, ensure the patient's external auditory meatus is in line with their sternal notch by placing the patient into either a sniffing or ramp position. Manual maneuvers such as a triple airway maneuver are also useful in improving airway patency. The triple airway maneuver comprises of head tilt, jaw thrust, and opening the mouth. Head tilt pulls laryngeal structures away from the posterior pharynx. Jaw thrust displaces the tongue forward, and opening the mouth ensures airway patency even where there is an occlusion at the level of the soft palate. After a patient's airway is cleared of soft tissue obstructions using manual techniques, it is important to ensure that it remains patent and does not re-occlude. This is where airway adjuncts such as an oropharyngeal or nasopharyngeal airway are useful. A properly fitted OPA prevents the tongue from falling back against the posterior pharynx and also assists in keeping the mouth open. To select the correct size, measure from the center of the patient's incisors to the angle of the jaw. Next, place the OPA into the oral cavity with the tip facing the roof of the mouth. Once inserted halfway, turn 180 degrees and continue to insert the OPA until the flange rests against the patient's lips. A properly placed NPA also has the added benefit of preventing the soft palate from occluding the nasopharynx. To identify the correct size, measure from the corner of the nose to the earlobe. Lubricate the distal end and advance the NPA along the floor of the nasal cavity until the flange rests against the nostril. Once airway patency is maximized, attention should turn to maintaining a good mask seal. To do this, an appropriately sized mask with a 2-person BVM technique should be employed using either the CE or thumbs down grip. In either case, be careful to not push the mask into the face, but rather lift the face into the mask. Even with good 2-person BVM technique, some patient characteristics make obtaining an effective mask seal challenging. In patients with no teeth, improving the mask seal may require putting dentures back into the mouth, bunching the cheeks, or resting the bottom of the mask against the lower lip. If none of these techniques work, you can even try removing the dentures and packing gauze into the buccal cavity. When it comes to patients with facial hair, improving the mask seal may involve clipping the beard, applying an occlusive dressing around the beard, or using a pediatric face mask to ventilate the nose while the mouth is closed. After doing absolutely everything you can to optimize BVM technique, it is imperative to measure whether it has succeeded or failed at ventilating and oxygenating the patient. Successful ventilation can be indicated by adequate rise and fall of the chest, confirmation of air entry via chest auscultation, as well as a normal end-tidal CO2 waveform. Successful oxygenation can be indicated by normal skin color, SpO2, and heart rate. If these indicators are present, then bag mask ventilation has been successful and should be maintained until the patient wakes up. If, however, these indicators are not present, then bag mask ventilation has failed and a quick transition to a supraglottic airway must occur. Many types of supraglottic airway devices exist. However, in Ambulance Victoria, we currently use the iGel. Once an appropriately sized iGel is lubricated, insert it over the tongue and against the hard palate. Keep advancing until definitive resistance is felt, indicating that the tip of the iGel is seated in the upper esophageal opening. Attach a BVM and attempt ventilation. If ventilation is ineffective, several strategies can be employed to improve the position of the eye gel. This includes applying gentle rotation of the eye gel with downward pressure, asking your partner to perform jaw thrusts, selecting a different size eye gel, and modifying the patient's position. If the patient is still not demonstrating signs of being adequately ventilated and oxygenated, then the supraglottic airway has failed. This is now a can't intubate, can't oxygenate scenario, and a declaration to activate Plan D and obtain front of neck access must be made. Obtaining front of neck access via cricothyroidotomy is indicated in patients who cannot be ventilated and oxygenated using an ETT, BVM, or supraglottic airway device. There are no contraindications in such circumstances. In Ambulance Victoria, a cricothyroidotomy is performed using the Quick-Trach 2 device. To perform the procedure, first ensure appropriate PPE is worn, including gloves, goggles, and a P2 mask. Hyperextend the patient's head to assist in identifying the cricothyroid membrane. To do this, feel down the anterior neck to locate the thyroid cartilage. As you continue to move your fingers downwards, you will eventually feel a soft depression just before the cricoid cartilage. This soft spot between the thyroid and cricoid cartilage is the cricothyroid membrane. Mark it with a horizontal line if not already done so. Lay the equipment on a clean cloth and test that the cuff is functional by inflating and deflating it with air. Attach a second syringe filled with saline to the back of the Quick-Trach 2. Swab the area and stabilize the cricothyroid membrane by applying traction to surrounding tissue using your index finger and thumb. Next, use a scalpel to make a vertical incision about 2 to 3 millimeters deep, but do not cut through the membrane. Then, while holding the Quick-Trach 2 on a 90-degree angle to the neck, puncture the cricothyroid membrane. Keep advancing until the red stopper is in contact with the neck. You should now be able to pull back on the syringe and aspirate air. This will indicate that the needle is in the trachea. Remove the red stopper and then push the plastic cannula forward until the green safety clip clicks into position. This indicates that the needle has retracted back into the plastic cannula and avoids the possibility of perforating the posterior tracheal wall. Now it's time to advance the device until the flange rests on the neck. Once this is done, remove the metal needle, inflate the cuff with 10 mL of air, and attach the BVM to the cannula. Deliver initial ventilations to confirm placement via capnography. Successful placement can also be confirmed by checking rise and fall of the chest, air entry on auscultation, and improvements in SpO2 and skin color. Once confirmed, you can secure the Quick-Trach 2 with a foam neck tape. In patients with significant adipose tissue or swelling around the neck, it might be difficult to locate the cricothyroid membrane. In these cases, it may be necessary to make a deeper than normal vertical incision using the scalpel. This will also reduce the force needed to enter the trachea with the Quick-Trach. Once you have inserted the Quick-Trach, if aspiration of air into the fluid-filled syringe does not occur, remove the red stopper on the Quick-Trach to allow deeper insertion of the needle until aspiration of air is possible. Once the device has been secured in place with a foam neck tape, it is time to turn our attention to post-cricothyroidotomy care. One of the first priorities is to commence adequate ventilation and oxygenation. It may seem obvious, but as a patient has foregone effective ventilation and oxygenation for a relatively long period of time, their SpO2 may be unacceptably low, while the end-tidal CO2 may be excessively high. If this is the case, an immediate focus should be directed towards bringing these numbers back to normal. This may require an increased respiratory rate for a short period of time. It is important to remember that although the respiratory rate can be safely increased, the tidal volume should remain the same at 6 to 7 mL a kilo. This maintains a lung protective strategy and reduces the risk of lung injury and hemodynamic compromise. Once the patient's SpO2 and end-tidal CO2 have normalized, the respiratory rate can return to 12 to 16 breaths a minute or according to clinical need. As the internal diameter of the plastic cannula is only 4 millimeters, a slightly higher inspiratory pressure using the BVM may be required when delivering the 6 to 7 mL a kilo tidal volume. It is important to note that in AV, row microparamedics must continue to manually ventilate the patient via a BVM and refrain from switching to a mechanical ventilator. The Medumat mechanical ventilator is not suitable for use with cricothyroidotomies and has therefore been listed as a contraindication by AV. An important decision to make is whether to continue positive pressure ventilation via the Quick-Trach or allow the patient to wake up and resume self-ventilating. The answer to this will depend on several factors, including the reasons for the initial intubation attempt, as well as the patient's current status. If, however, the decision is made to continue positive pressure ventilation via the Quick-Trach on the way to hospital, then post-procedural sedation must occur. It may be beneficial to start with an initial bolus of sedation to ensure an effective therapeutic level before setting an infusion rate. One final consideration is whether to use long-term paralysis. Unlike an ETT, a Quick-Trach only provides a 4mm hole in the neck, which for a full-size adult patient is incredibly hard to spontaneously breathe through. In fact, the high negative intrathoracic pressure required to suck air through the tiny hole can even cause complications like negative pressure pulmonary edema. Therefore, if the Quick-Trach is to remain in place, then paralysis should also be provided to prevent spontaneous breaths. Thanks for watching.